Hello and welcome to this talk about insomnia, the clinical picture and the diagnostic procedure. My name is Erla. I am a clinical psychologist with a PhD in sleep medicine, and my expertise lies in insomnia and cognitive behavioral therapy of insomnia. The learning objectives of this talk today is to understand the clinical picture of insomnia, to identify the diagnostic criteria for insomnia, to learn about different subtypes of insomnia, and also to learn about risk factors, comorbidities, and consequences of insomnia. Insomnia is considered a 24-hour disorder because its impact extends beyond nighttime sleep difficulties. While it is commonly associated with troubles falling asleep, staying asleep, or waking up too early in the morning, insomnia also affects daytime functioning, and individuals with insomnia may experience fatigue, irritability, difficulties in concentrating, and reduced productivity throughout the day. The cycle of poor sleep and impaired daytime functioning can create a continuous round-the-clock issue that significantly impacts overall health and quality of life, making insomnia disorders that affects every hour of the day. Insomnia often turns into a vicious cycle with a pattern where unhelpful thinking, emotions, and behaviors maintain sleep difficulties. It often begins with unhelpful thinking, such as worrying about the consequences of not sleeping, which can lead to unhelpful emotions, such as frustration and anxiety. And these emotions make it more difficult for patients to fall asleep and stay alert, further complicating the ability to sleep. In response, the person often engages in unhelpful behavior, like going to bed too early, clock watching, or tossing and turning during the night. This can increase wakefulness and alertness during the night. And this cycle often repeats, reinforcing the insomnia and often making it difficult to break the cycle without intervention. Hyperarousal is common in patients with insomnia, and it refers to an increased state of psychological and physiological alertness. In the context of insomnia, it is often characterized by heightened activity in the nervous system, which makes it more difficult to sleep and stay asleep. Individuals with insomnia often exhibit physiological signs of hyperarousal, such as elevated heart rate, increased metabolic rate, and higher levels of cortisol, which is the stress hormone in the body, even during sleep. And this can, of course, impact sleep quality. Hyperarousal is common among insomnia patients, and this refers to an increased state of psychological and physiological alertness. In the context of insomnia, it is often characterized by heightened activity in the nervous system, which makes it more difficult to fall asleep and to stay asleep. Individuals with insomnia often exhibit physiological signs of hyperarousal, such as elevated heart rate, increased metabolic rate, and higher levels of cortisol, the stress hormone in the body, even during sleep, which impacts quality of sleep. Hyperarousal in insomnia patients can also include a mental component where the brain remains overly active, often leading to racing thoughts, anxiety, and the inability to shut off at night. The effect of hyperarousal are not limited to nighttime because people with insomnia often experience daytime symptoms such as irritability, fatigue, difficulties with concentrating, and a general feeling of being on edge. High levels of stress, whether it's from work, relationship, or other life events, can trigger insomnia, and it's one of the most common risk factors for insomnia. Chronic anxiety, where the mind is constantly racing with worries, can significantly increase the risk of developing sleep difficulties. Poor sleep habits, irregular sleep schedules, excessive screen use before bedtime, a lack of bedtime routine are all factors that can disturb the body's circadian rhythm and lead to insomnia. Lifestyle factors are also important. The consumption of caffeine, alcohol, and nicotine can all disrupt sleep. Caffeine and nicotine are stimulants, while alcohol can disrupt the sleep cycle, leading to more fragmented sleep. Poor mental and physical health, such as depression, chronic pain, or other chronic conditions, can also lead to difficulty sleeping, and lead to symptoms of insomnia. Insomnia also becomes more common with age. Older adults may experience changes in sleep patterns, decreased sleep efficiency, and an increase in medical conditions and medications which can all affect sleep. Women are up to 40% more likely than men to experience insomnia, particularly during hormonal changes such as menstruation, pregnancy, and menopause. This is partly due to the impact of hormonal fluctuation on sleep. People who work night shifts or have irregular work schedules are also at a higher risk for insomnia due to the disruption of the circadian rhythm. There is also some evidence suggesting a genetic predisposition to insomnia, making it more common since it runs in families. Insomnia is a common disorder. It affects approximately 10 to 30% of the global population, and about 10 to 15% of adults worldwide suffer from chronic insomnia, where sleep disturbance occur at least 3 times per week and persist for 3 months or longer. Insomnia often co-occurs with other sleep disorders, such as sleep apnea, which can further complicate diagnosis and treatment, but I will come back to that later in my talk. It's also important to look at different subtypes of insomnia. Initial insomnia refers to difficulties falling asleep, whereas middle insomnia describes a condition of waking up during the night and being unable to fall back asleep. And then we have late insomnia, which is described by early morning awakenings. It is important to look at these different subtypes since they may have different risk factors and different consequences for patients. The diagnosis of insomnia typically begins with a detailed clinical evaluation. This includes a comprehensive patient history, focusing on sleep patterns, daytime symptoms, lifestyle factors, and any underlying medical or psychological conditions. Patients are often asked to maintain a sleep diary for 1 to 2 weeks before diagnosis is made. The sleep diary tracks the sleep onset duration, awakenings during the night, perceived sleep quality, and provides a valuable insight into the patient's sleep patterns. Clinicians may inquire about the patient's sleep environment as well, bedtime routine, lifestyle factors, stimulants, and so on. Evaluating the impact of insomnia on daytime functioning is critical. Patients are asked about fatigue, mood disorder, cognitive impairment, and how insomnia affects their work, social, and family life. It is also important to go over all medication that patient is using, since some drugs can cause or exacerbate symptoms of insomnia. This includes over-the-counter medications, prescription drugs, and supplements. The diagnostic process involves ruling out other sleep disorders that might exacerbate insomnia, such as sleep apnea, restless leg syndrome, or circadian rhythm disorders. This is often done through a combination of clinical history and, if necessary, sleep study. Actigraph can be used in the diagnosis of insomnia, and Actigraph involves wearing a wrist device that monitors movement and provides an estimate of sleep patterns over several days of week. It can be useful in cases where sleep diaries are either unreliable or where insomnia is expected to have a circadian component. Polysomnography, or an overnight sleep study, is not routinely used in the diagnosis of insomnia, but may be indicated if other sleep disorders are suspected, such as sleep apnea. A sleep diary is an essential tool for the diagnosis of insomnia, and it provides a detailed insight into the individual sleep pattern. And in this slide, you can see an example of how sleep diary can look like. It tracks habits, quality of sleep, lifestyle factors, and sleep patterns. By tracking this information, such as bedtime, wake time, frequency of awakening, and perceived sleep quality, healthcare providers can identify patterns that may contribute to insomnia. The data helps to distinguish between different subtypes of insomnia, also to understand the severity of the condition and tailor treatment plans effectively. Additionally, a sleep diary encourages patients to become more aware of their own sleep behaviors, which can be crucial in successful treatment outcomes. Insomnia is very common in primary care, and up to 50% of patients who attend primary care experience some symptoms of insomnia. And we know that insomnia is often under-recognized and under-diagnosed in primary care. And a recent study found that in 75% of cases where patients indicated insomnia as a problem for more than 12 months, only around 11% had discussed the problem with their physician. And this underlies the importance to screen for insomnia in primary care. If we look at the diagnostic criteria according to the DSM-5 for insomnia, it includes difficulties initiating or maintaining sleep or early morning awakenings. The sleep difficulty must occur at least 3 nights per week and be persistent for at least 3 months. The sleep disturbance must cause some daily impairment, such as clinically significantly distress, impairment in social, occupational, educational, academic, behavioral, or other important factors of life. The sleep difficulty also occurs despite adequate opportunity for sleep, and it's not explained by substance abuse or by other medical or comorbid conditions. This does not mean that insomnia cannot be comorbid with other conditions, because it is frequently comorbid with both medical and psychiatric conditions. Managing insomnia in patients with comorbid disorders often requires a comprehensive treatment approach which addresses both the sleep disorder and the underlying or associated conditions. Early identification and treatment of insomnia can really help to improve outcomes for these comorbid conditions. Insomnia is prevalent among individuals with chronic pain. We know that pain disrupts sleep, and poor sleep can also worsen the pain perception and create a vicious cycle. We also know that insomnia and obstructive sleep apnea often co-occur, creating a condition which is called COMISA. This combination can significantly worsen health outcomes, as both conditions disrupt sleep and contribute to daytime fatigue, cognitive impairment, and increased risk of cardiovascular disease. Treating one condition without addressing the other can be ineffective, so a comprehensive approach that manages both insomnia and sleep apnea is crucial for improving sleep quality and overall health among COMISA patients. This image illustrates a significant overlap between insomnia and sleep apnea. We can see that in those with sleep apnea, 30 to 50% of patients also experience insomnia symptoms. And if we look at those who have insomnia, around 30 to 40% of those patients also meet the criteria for sleep apnea. It is therefore extremely important to screen for both for OSA among all insomnia patients and vice versa. Chronic insomnia has a widespread impact on both quality of life and physical and mental health. It can lead to persistent daytime fatigue, cognitive impairment, and increase the risk of mood disorders like depression and anxiety. Physically, it weakens the immune system and raises the risk of cardiovascular disease, obesity, and diabetes, especially if insomnia is associated with short sleep duration. Socially, insomnia can strain relationships due to the irritability and mood swings, reducing overall quality of life. And we also see an economical consequences, since insomnia leads to decreased productivity, higher healthcare costs, and increases reliance on medications. So early interventions is crucial to prevent these negative consequences on daytime functioning, quality of life, and overall health. So to conclude, insomnia is a common sleep disorder with older people and females at increased risk. A clinical interview and a sleep diary is crucial for making an insomnia diagnosis. Polysomnography may be appropriate, especially if there is a suspicion of other sleep disorders, and insomnia has various negative impact on health and quality of life. I want to end this talk by an assignment, a case presentation, where I encourage you to work in small groups and prepare a case presentation on insomnia. So each group will present a hypothetical, okay. I want to end this talk by a small assignment where you work together in small groups and prepare a case presentation on insomnia. So each group will present a case, including patient's history and the diagnostic findings. Thank you very much for your attention.